Welcome everyone. Welcome everyone attending our July Lunch and Learn Forum or program by Zoom. Today we have the pleasure of having presenters Mahree, Skala, and Steve Galloway, who will talk on minority health disparities. But before we get to the program, I wanted to make a couple announcements and thank yous. I first want to thank Sharon Schneeberger, as always, for controlling and orchestrating and setting up the Zoom program. I want to thank all of you who are listening. This will also be recorded and you can listen to it or have your friends listen to it and share it on Facebook, and it's on the League of Women Voters, Columbia Boone County website and Facebook also. And then I wanted to announce two upcoming programs, forums that we're having. This Thursday at 7 p.m. We'll have the human impact of Medicare expansion, and that will be with Dr. Heidi Miller from the St. Louis Regional Health Commission and Jack Cardetti, who is with Yes on 2 campaign. And then on July 23rd, next week, we have our candidate forum for the primaries for the Republican Boone County race. And that would be just the Republicans because there are no challengers for Janet Thompson's Democratic spot, who is the existing Boone County commissioner. So with that, I want to again thank Mahree, Skala, and Steve Galloway for being our presenters today. They'll be talking about minority health disparities, specifically in health and the social determinants of health and the implications for universal health care coverage. And just as a little introduction, Mahree is a longtime League of Women Voter board member, Columbia resident. She's been with the Missouri Department of Health and Senior Services, and then executive director of the Missouri Association of Local Public Health Agencies. She's presently on the Boone County Health Board, and she chairs the League of Women Voters Local Health and Mental Health Committee. And Steve Galloway is also a longtime Columbia resident. He was a pharmacist with the University Hospital for 37 years and director of pharmacy for the Missouri Medicaid program, MoHealthNet. And many of you also know him as a Columbia School Board member from 2006 to 2009, as well as I think an organizer and longtime member of the Minorities Men's Network. So with that, I will hand the program over to Mahree and Steve. Oh, and one more mention, there is a question chat feature with Zoom. So if you have questions, please put those on chat, and then at the end of the program, we'll allow maybe 15, 20 minutes for questions and answers. So feel free to put your questions in during the presentation as well as at the end, and we'll try to get to as many as possible. Leave it up to you guys. It's
okay.
Let's Steve get started.
Well, super. Well, thanks so much, Barbara, for introducing us, and to the League of Women Voters for inviting us to do our little talk here. You'll see on the slides that Mahree and I prepared is that there's a little logo on the bottom right on most of the slides that says Physicians for a National Health Program. And while neither of us are physicians, the group is led by, at the national level, by a group of physicians who got together and said, well, you know, we think the United States needs some kind of national health plan. And so certainly that's not a unique perspective to physicians. Many of us in healthcare and in healthcare policy, which is where Mahree and I have been definitely recognize the need to do something about the healthcare system that we currently have in the United States. So we'll go along, get started on this. I'm delighted to work with Mahree on this because I so appreciate her engagement and the long introduction of all the stuff that she's involved in. And so I just try to run after her and get just catch some of the wind from her coattails. So anyway, and I appreciate. Go ahead, Mahree. I'm sorry.
I said it's the other way around. Sharon, are we sharing the slides now?
I
Can you do it?
I think we're working on putting the slides up so for all the viewers, just hold on with us for a moment. I think this is our first slide sharing program.
Steve, are you sharing?
No, it's Mahree who has the slide set, I think. So,
All right, well, you have permission to share.
okay. Is it showing now?
Yes,
Yeah.
yes it is.
Okay,
Yay!
Yay!
Great.
Success. All right.
Awesome.
Steve, tell me when to advance and I'll try to do that.
Okay, great. Yeah. So Mahree and I, racial health disparities, and we thought this was a great opportunity to make the case for Medicare for all. And if you don't, if for some reason you can't go all the way along with Medicare for all, we would invite you to at least consider doing something different around our healthcare system. And the part of the context for this is that COVID-19 has created the opportunity for that. So here's where we're going. Thanks for changing that slide, Mahree. Racism is embedded in our major systems of society. Think education, the legal system, our economic system, housing, and health care, which is where we want to land today. But remember, these are not isolated systems. They are actually very interrelated. And the disparities are a result of a fragmented health system that puts profits over patient health. We'll try not to editorialize too much on that aspect of it, but that's the way it is. COVID-19 pandemic has exacerbated our health inequities in the United States, and single-payer Medicare for all can help heal racial health inequities. And we'll try to be more explicit about how we think it can do that. So we'll start off talking about some Boone County health disparities. And thanks to Mahree for pulling this piece of it together, because she's been closer to this from a data standpoint than I have. So Mahree?
So I just want to comment that interspersed throughout the regular slide set, you'll see local data, and I'll kind of describe that some of that for you as we go forward. But I wanted to be sure to cite the sources. All of the data that will be shown in the presentation come from the Missouri Department of Health and Senior Services and or the Boone Indicators Dashboard. And for those who aren't familiar with the Boone Indicators Dashboard, it is a wonderful source of information about all kinds of things about our community. And I encourage you to explore it. You can just Google it and it comes up. So.
Great, great. So as we get started, we're going to just let you know that some of the data that we have comes from a couple of preparations and presentations that the PNHP group put together. So some of them you'll see a very nice lady named, physician named Claudia Fegan, who actually gave a talk at the University of Missouri at the Health Sciences Center back several months ago. And we kind of stole some of her slides from a presentation she did, as well as a PNHP a presentation. So this information, we've actually verified this information as well. So it's spot on. So we're just going to go through some very quick things that kind of try to put you put a focus on the problem, or best, tell us what the issue is. So this first one, the statistic is that early death among Blacks is a uniquely American problem. And Mahree, you'll probably have to hit all the keystrokes to bring up all the lines that are part of this slide. So you'll see that the very bottom, the blue line, or green, I don't know what it looks like for you, it shows white men, and it shows that the deaths have been declining. Overall, the trend is declining. But the key point is that white men in the US have the lowest rate of early deaths per 100,000 people. And even Black men in other countries, 66 other countries, have a lower rate of death per 100,000 people compared to Black men in the USA. So that suggests that it doesn't have anything to per se to do with the fact that they're Black. It has to do more with the fact that they live in the US compared to other countries. So next slide. So this next slide that you see here, again, in reference to Black lives, Black lives in general are 3.5 years shorter than white lives. And that is looking at the life expectancy in 2017 data. Life expectancy at birth, you'll see Black Americans 75.3, white Americans 78.8. So this is men and women, which, women, drive that life expectancy up for all of us, because the guys go earlier than the women do. Next slide, please.
And if I'll jump in here, this is the similar data shown for Boone County specifically. And sadly, our disparity is even greater than the national disparity. Our white life expectancy from birth is 80.4, so that's better than the national average. But for Black Boone Countyans, it's only 74.7 years. So that's a 6-year difference in life expectancy here in Boone County.
Yeah. And next slide. The next slide, again, gets back to some national data. And you'll see that there are a variety of medical conditions that shorten Black lives, not intended to be an all-inclusive list, but certainly some key medical conditions that we see. Homicide falls out of that box, as you see, and many times you hear about people dying, from being killed, as well as talk about some folks that you hear about the car accidents are a major source of death among people. And so we're just talking mostly about medical conditions. The homicide rate is put up there just as a comparison. And you'll see that heart disease and cancer are two medical conditions that more than any other shorten Black folks' lives. And so again, this is pointing to the disparity, and it's been suggested, data suggested that medical prevention and treatment would help eliminate 86% of the difference in life expectancy. In other words, that's suggesting that we attribute some of that shortening to the fact that there's a problem with prevention and with access to treatment that could be remedied by addressing those two issues. Next slide.
To expand on some of those national statistics again and bring it a little closer to home, the heart disease death rate in Boone County, according to the most recent figures, is 1.5 times greater for Black Boone Countyans, which is this bar right here, 214 per 100,000 residents, compared with white residents at 139 per 100,000. So again, bearing out the national discrepancy, and it's very, very marked here in our own home county. Diabetes, this is hospitalization data, and the disparity for diabetes, oh, darn it, there. The disparity for diabetes, excuse me, sorry, it seems to want to advance itself.
It's pretty touchy.
There we go.
Yeah, anyway, I don't want to dilute the point because it's an important one. 4 times as many Black people in Boone County are hospitalized with diabetes as their primary diagnosis than for whites. So it's a huge discrepancy here.
Yep. Yep. Definitely. And the next slide again points to some specific medical conditions that shorten Black lives. Breast cancer is one that we talk about. And I know, for instance, here in Boone County, the University of Missouri and over at Alice Fischel, they've had some initiatives focused on trying to get screening for breast cancer. Because breast cancer, as we know, is one of those diseases that early detection makes a huge, huge difference. And so the statistic we see is that high quality insurance can mediate 46% of the difference. That is, if folks understand and believe that they can get treatment, that is, if they seek and take care of their regular mammograms and the things that are intended to help detect breast cancer early, they have a better outcome, as you see. So the Black women presented 20% versus 11% when it's the percentage that first presented, and then the survival rate you see is greater for white women, which we think that's because they have better access to insurance and to medical care as a result.
So they're diagnosed earlier and therefore have much greater chance of survival.
Yes, yes. Now, there are some conditions, again, and we may get to some of those. We probably will get to some, so I'll just wait on that right now. So next slide there, Maureen.
Oh, well, this is showing another indicator related to women's and infants' health. This is infant mortality as measured by the number of infants who die before they reach their first birthday. And again, you can see there's a discrepancy. It's about 2.5 times higher rate among Blacks than among whites here in Boone County. And anytime this happens, it's a tragedy. If we look, darn it. If we look at the, okay, here we are. If we look at the discrepancy in terms of low birth weight babies, and I didn't do a graph on that specifically, but the disparity is even greater. So one of the causes of these infant deaths is prematurity, low birth weight. Babies born too small to survive.
Yep. Yep. And of course, you know, in Missouri too, you know, that, you know, we have the lowest cigarette tax pretty much in the nation. And that's been shown to reduce smoking, you know, the rate of smoking. And so when you start talking about women who smoke, which smoking is a contributor to low birth weight infants, there are any number of things that you could point to that create this disparity. But as part of what, you know, when we talk about this, is that it's really after all these advances that we have in medicine, infant mortality and maternal mortality also has gone down. It has, mortality has gone up for African American women and families, which is, it's incredible. How do we miss that? That's, you know, topic for another another presentation, but huge disparity in that, even in this day and time. Next slide. So you'll see there are some, there we go, maternal mortality. This is exactly what we're talking about, that the rate for Black and Native Americans is there's really, and Asian Pacific is compared to whites, it's terrible. It's quite high, quite high. This is really one of the problems that we've not been able to solve. And it's believed that 63% of pregnancy-related deaths actually were preventable. Next slide.
Another,
I think it went 2, no? Yeah, that's right. You're good.
another condition that affects minorities in a disparate way in Boone County is asthma. And this is data, this is a little older data. It's from 2005 through 2014. And the Department of Health and Senior Services no longer publishes this. So I couldn't update the numbers, but I don't doubt that it looks very similar today. This shows the difference in preventable hospitalizations for asthma in different age groups among kids under 20. And as you can see, this is an extremely high disparity, especially between the ages of 1 and 10, but really throughout childhood, that many more African Americans proportionally end up hospitalized for asthma and preventable hospitalizations. And if you sense a theme here, the main point we're trying to make is that these differences are not baked in genetically. These differences are not related to some immutable factors. They're related to lack of access to care and lack of healthy living conditions. And we'll get into those determining factors a little later, but I just wanted to make that point.
Yeah, you got the next one there, Mahree, I think.
Oh, okay. So what are the determining factors? Well, we know that health in general and several of these diseases specifically are highly correlated with income, education, access to decent housing, access to health care, which we've mentioned several times, healthy diet, physical activity, and stress, and the amount of stress in people's environment. And I think we've all been sensitized to the amount of stress that African Americans are subjected to in many realms of their lives in recent months. That's really come to our attention more than it has before, but it's also true that there are large disparities in income, education, housing, and access to health care. So,
yeah, and the data indicate that income and education are the 2 top factors. And I would submit that housing, particularly as we've been looking at housing and housing policy and affordable housing and people being unhoused as a term, is a very, very close third. And stress, particularly in the context of COVID and other things going on, and then as they tie back to these other factors, have a lot to do with how healthy people are. There's some studies that say that the zip code that you live in determines very much what your outcome's going to be like, including your health.
And to bring it down to the local level again, this is data from the city of Columbia in the kind of teal color and Boone County in the green, showing the income disparity. And we're a little unique here in Columbia in being a university town. You can't just look at the income of single people because it's so skewed by the number of single person households who are students and whose income is coming from other sources like their parents. So what we do is look at family household income. These are households that have more than one person in them, so therefore would include households with children. And as you can see, the disparity is huge. White people in Columbia and in Boone County make about twice as much average per year than Blacks do. And that's, of course, related, as Steve said, to education level. It's also related to various forms of discrimination in hiring and just the types of jobs that people are able to get, which also directly affects their access to health care, because the more you're paid in your job, the more likely you are to have health insurance provided as well. This shows high school graduation rates, to get back to the point about education. And while this disparity has been closing over time, there's still a significant gap in high school graduation rates, as you can see. 90% of white students graduated in the Columbia Public Schools, from the Columbia Public Schools in 4 years, whereas only 80% of Black students did.
Yeah. Next slide. We'll keep on running here. So deaths during 2019 due to uninsurance. Again, this is an estimation that, you know, some folks like the Kaiser Foundation, in this case, this was from an Annals of Internal Medicine article and study that suggests, it tries to approximate or estimate the number of deaths that are due to people not having insurance. And those are considered excess deaths. In other words, you know, if somebody dies and they have insurance, right? Well, okay. But having insurance is attributes, not dying, I should say, is attributed to having insurance. You know, a death that wouldn't happen had somebody had access to care. And so you'll see that in various states, it varies. Anywhere between 5.5 for the states that it looked at here, up to 18.1%. And overall for the United States, that's 9.1 of our population, which equates to about 38,000, almost 39,000 excess deaths that we could have prevented from insurance. And at a time when we're talking about, you know, what we do around COVID and why is it a good idea to mask up, and why are we trying to look for a vaccine? Why aren't we just letting herd immunity take care of things, right? Why aren't we just letting nature take its course? Those are excess deaths. In other words, deaths that didn't have to occur. So I think this is a pretty startling figure that I don't think you see this very many places. Next slide. So there's another statistic here that tells us that until the age of 65, people of color are more likely to be uninsured. And this is kind of, and so this points to the percentage of each Black, Hispanic, Native Americans, and whites that between the ages of 0 and 64, based on 2017 data, are without health insurance. And so you'll see that Native Americans, it's pretty high. It's the highest of all of it. But Black is 11%. All of these point to a disparity among people of color compared to whites. So there's a quiz question here. Let me back up. I'll wait on that. Because, let me back up. Why do you think we say until age 65 that this is the case? And maybe a corollary to that is, what do you think happens to it when you hit age 65 and beyond? So the answer to the question is, what do we become eligible for at 65? Regardless of whether you're Black, white, or what, we all gain access to Medicare at age 65. So that's why this is an important statistic, because even if you don't have insurance all the way up through your working time and maybe a little bit of retirement, at 65, everybody gets Medicare. Hopefully you see where we're going here. Next slide. So this just points to the data that say that uninsured and underinsured being underinsured or non-insured leads to a delay in seeking care for heart attacks. And what happens at hospitals? Hospitals have a door to cath lab statistic that they keep track of that says, you know what, we're always trying to reduce the time from when someone shows up at our door in the emergency room to the time we get them to the cath lab and open up that blood vessel because they're having a heart attack. And so if that's so important, how crazy is it that some people don't even get access to that initial place of getting to the hospital to get care for that heart attack problem? So this is estimated, the odds ratio for delayed care, that if people who are uninsured and uninsured are much more likely to have delays in seeking care for heart attack. It's like, yo, duh, right? Next slide. And then finally, as we look at this, this is maybe something that folks don't think about, but certainly when it comes to medical debt and reasons why people file bankruptcy and that sort of thing, past due medical debt is a problem, in particular for Black Americans. There was a review of the percentage of folks, whites and Black, who have past due medical debt between the ages of 18 and 64. This is an older set of data, that 31% of Black non-Hispanic folks have past due medical debt compared to white non-Hispanic. So at a time economically when there's already disparity, this just adds on, piles on, if you will, when it comes to the problems that we have that in large part are created by our healthcare system, the way it currently operates. Next slide. So this is the question that we're trying to pose to you and answer. And it's in the context of Medicare and Medicaid in 1965, that in conjunction with the Civil Rights Act of 1964, they were transformative in desegregating the nation's healthcare system for patients and providers and improving access to care. But the question is, what could Medicare for all do to improve the racial health inequities of today? So we want to propose maybe some things that might be. But before we do, the next slide. So we want to hit on this little COVID thing a little bit. So you may have heard people say, we're all in this together. Everybody's going through this same thing. Well, yeah, that's true. But if you put it another way and you say we're in the same storm, but we're not in the same boat, that's going to point you to the idea that some people with this COVID stuff may not be navigating the waters as well as others. And some of that points to the economic situation that people are in. Some folks are getting, making money on the COVID-19 situation. Other folks who've been laid off, lost jobs, furloughed, are worse off, have trouble making their rent or their mortgage payments. Some people have insurance, some people don't have insurance. Some people are sicker than others, some people are better off than others when it comes to health. So this is a thing that I wanted, I was impressed by this, the fact that it's not the same experience of everyone when it comes to how we're dealing with COVID right now. Next slide. So when we talk about some other statistics here, just real quickly here, and this is to kind of put a, we're comparing the United States to a country that has national health insurance, Canada. And we're not going to get into, is Canada better than the United States or whatever, but if you just look at the race and ethnicity information in regards to maternal mortality compared to Canadians, then what you see is that for every group, even whites, we do worse than Canada that has national health insurance, okay? So that kind of gives a nod maybe to some type of a different system of healthcare that gets provided in that country. Next slide. So let's talk more specifically about the disparities that are associated with COVID-19. And this is from a recent, from the CDC's website that was just updated June 25th, 2020. So one of the things we know for a fact that the CDC's reported on is that there are higher rates of hospitalization or death for minorities, people of colors, compared to whites. So that's what the words that aren't on this slide, but it is compared to whites. So non-Hispanic American Indians and Natives, 5 times higher. Non-Hispanic Blacks, 5 times higher. Hispanics, Latinos, 4 times higher. People of color under the age of 65 die from coronavirus at twice the rate of whites.
And
Next.
if
Yes,
I can
go ahead.
add, I don't have a slide for it, but the Boone County data I just checked this morning show that while African Americans comprise about 8% of our population here in Boone County, 16.6% of the cases of coronavirus have been in African Americans. And unfortunately, they don't break down the hospitalization or data by race, but certainly the number of cases reflects a disparity here locally.
So next slide, please. So this gives a little bit of a nod to the why. So CDC, again, from their website, identifies living conditions, work conditions, and health circumstances. And these aren't all of the particular elements of it, but I've tried to highlight for you the particular things that relate to health that seem to maybe have the most impact on health. And under living conditions, it's multi-generational housing. So if you talk about COVID, when one person gets COVID, everybody in the house is probably going to get the COVID, and it's more folk that are actually living in the home. And then the fact that under work conditions, people who are essential workers have to go to work and maybe go to different jobs. And then when they come back to the home, you've brought back whatever you got when you were out there. Related to insurance and healthcare also, we know that many of these workers don't have sick leave. So they're more likely to go to work because they have to go to work. They can't not have a paycheck. And so maybe they take Tylenol before they go when they're sick. And with COVID, sometimes many people are kind of asymptomatic. And so they don't have any qualms per se, not that they want to make anybody else sick, but they may go to work when they shouldn't go. And then the other huge thing that I've probably heard the most about is insurance tied to employment, which we'll talk about that in just a minute too. But people who've been laid off and furloughed, again, if you got the money to pay for the COBRA premium, yeah, you can keep your insurance if you had it through a group plan. But these may be folks who already were having trouble with copays. We have people who have these insurance plans, even under like the Affordable Care Act, that they have these high deductible plans. So is that really working? I don't know that it really is. And then we've already talked about how much more frequently and likely that folks are to be uninsured. And we see also that there's data that they're more likely to report costs as a reason for not visiting the doctor. And I do want to throw in here too, that the data that the CDC has published includes Native Americans as well. And so we know that on reservations, on the lands where those people live, some of those folks had inadequate or no plumbing as well. So that's a crazy thing. And then hit that space bar one more time. And then fourth, reasons not studied or fully understood. Why? Because we don't have we don't have funding to do any studies to look at the why of these things. Again, these were things that existed before COVID. If you go, take this slide, speed it back to the previous slide, and you'll see that these are things that existed before we got COVID. Next slide. So, Mahree, I'll let you talk about this one here because this actually gives the comparison of what Medicare for All might do and why it might be a good idea.
Okay. Even with this is a contrast between two of the big policy proposals that are before us as a nation now. A public option, in other words, a plan that people could opt into if they wish, but which is a government insurance plan, which is a theoretical because we don't have anything like that right now. I guess the closest thing is the children's health insurance plan, but we won't get into that. Or Medicare for All, which would be comprehensive lifelong coverage for everyone. One of the drawbacks of a public option, although it would insure more people, it still would not lead to universal coverage and might still leave a lot of people without coverage. And a public option wouldn't really help people that have the kinds of plans that Steve was describing, which a lot of working people do now. They have employer provided insurance, but the deductibles and premiums and co-pays are so high, and especially they have to pay so much out of pocket before their insurance even kicks in to the tune of thousands of dollars per year. So that a lot of the insurance that people have through work is basically just for a huge emergency. If they had a heart attack or if they had some really serious accident, it would kick in. But otherwise, they're paying out of pocket for their health care. Well, a public option would not apply to those people. We would still expect them to stay on those expensive, low-quality private plans. Whereas under Medicare for All, some of the proposals would be universal care, everything that's needed without premiums, co-pays, or deductible. Now, I think we don't have a slide on this, but I really want to bring Medicaid into the discussion here because this is from a national perspective, but from a state, more of a state perspective, we do have a third option, and that is the Medicaid program. And that is a program that insures people who are, well, it insures a variety of people, but currently the eligibility for it requires extremely low income. And for adults, it requires that they have dependent children. And the proposal that's on the ballot for August 4th would expand that to include adults without dependent children, and it would also raise the income requirements a little bit. So just want to throw that in because people, if you're not familiar with the lingo, Medicare and Medicaid are words that are so close together that we tend to think of them as the same program or mix them in together somehow. And they are really two separate programs. So here's another point about public option versus Medicare for All. Again, getting back to the out-of-pocket expenses for co-pays and deductibles. And for Medicare for All, then people would be able to get the care they need without all that. So another contrast here is the public option plans really don't equalize the funding or direct resources to underfunded facilities. This is where we get into the discussion about healthcare facilities that serve low-income populations and or rural populations. So many patients in low-income communities would still be uninsured. Whereas Medicare for All would be universal, all providers and all hospitals are compensated for patient care. And some of the proposals ask that the budgeting be based on community needs, obviously, rather than the profit of the healthcare companies. So, and finally, the big contrast is that the public option would be just one among many options and would still leave our fragmented system in place. And it really wouldn't provide any additional resources to research or combat racial bias and that leads to the disparities that we've been talking about here. Whereas a publicly funded health system could invest in better research and data and hopefully find more effective ways to combat these disparities.
Great.
You want to do this one, Steve?
Yeah, so we'll just speed through these real quick because we're right at the end of our time here. So this is just to show that, there are areas where systems already in place where racial disparities have very much so already disappeared because of the system itself. So dialysis, which even though Blacks are more affected by renal failure and kidney failure, that sort of thing, the observation is that Blacks survive longer than whites. The VA system does a great job of treating folks without disparity, and folks age 65 plus, again, because of the impact of Medicare and eligibility for that at 65, we find mortality rates more closely match across groups. So next slide then just ends up and says that, single payer Medicare could provide more freedom in our healthcare decisions, equality and justice when it comes to comprehensive insurance. If you believe healthcare is a right, we can make sure that everybody gains access to it. And that, again, this doesn't necessarily address all the other things in the system that result in inequity, but Medicare can have an important role in helping to level the playing field and reduce disparity and inequity in the system. So next slide. We'll leave you with Martin Luther King's quote there. And that's it for us.
I just want to add that to tie this into future league presentations, there will be a forum or an educational program Thursday evening about Medicaid expansion. And while Steve and I belong to a group that's advocating for a broader solution than that, we also are advocating very strongly for Medicaid expansion as an interim measure to get more people covered here in Missouri. And the issue that's on the ballot, it's Amendment 2 on August 4th, and it would expand Medicaid eligibility, as I said, to include adults under 65 who are low income. And when we say low income, for a single person, the income cutoff would be about $17,500 per year. So it's not, it would only cover people that would almost universally be considered low income, below the poverty level. But it would, the estimate is, cover about 230,000 more Missourians than are currently covered. So that would be 230,000 more people who have access to health care.
So I just want to thank you, Mahree, Skala, and Steve Galloway, for that excellent, informative presentation. And I think that gives us a lot of information, a lot to think about. When I checked a few minutes ago, we did not have any questions because you guys covered so much. I did have one short question. Well, it's really a long answer question, but hopefully you can answer it in a short way. And I think people are wondering about, that's how do you pay for Medicare for all? How will it be paid for? What are the options? If you can do a little paragraph on that.
Maura, you want to take that one on?
Oh gosh. Well, that's not an easy question.
We're not going to get into details.
Yes.
However, I will say that the estimates of the cost depend on what you put in the pot. And if you actually honestly compare what a Medicare for All system would cost compared to our current entire healthcare system and all of the insurance companies and all of the pharmacy benefit management companies and all of the administrative costs and all of the money that employers put into insurance, Medicare for All comes out cheaper than what we have now. So that's a subject for another program.
Yeah, I think you summarized that You summarized that very well. We did get one question in the interim, and that's, the question was, are insurance companies the main opponents of Medicare for all?
So I'll answer this one, and I'll type the answer in also. So yes, the short answer is yes. I would say that insurance companies are, stand to be losers when it comes to the government taking over healthcare. I won't say that has to be the way it is, but they are probably the biggest opposition to that. They contend that there would be thousands and thousands of people that would lose their jobs, that it would affect the economy. They're a huge employer, but they're also a huge influencer on what happens in healthcare. I would argue that the Affordable Care Act, although it was intended to give access to people to healthcare and has done so for quite a few people, it was originally intended as a win-win for health insurance. Because when you say you're going to give people access to health insurance, it means people are still going to the health insurers for their coverage. They're still paying premiums to the health insurers, whether it's the people and or the government combination, whatever, they're still being paid. And so, the idea that healthcare, whether you say managed care and all these different things which relate to Medicaid, they make a profit. They make a profit from people being sick. And if you believe that healthcare is a right, it shouldn't be a situation where people make money because people are sick. And so, anyway, the other opposition to Medicare is that providers say the Medicare rates are too low. And so they're reluctant to accept Medicare in many cases. And it's probably more so even the case for Medicaid. Mahree, you want to add on to that?
Yeah, I just wanted to add, if judged by the amount of money spent on lobbying against healthcare reform, the insurance companies and the pharmaceutical companies are the two big factors. The people who manufacture pharmaceuticals and who currently have carte blanche to charge whatever they want to do not want to see a system where there's bargaining power to bargain down those prices for drugs. So
Yeah, thank you for adding that, because I see so many advertisements on television for this pharmaceutical or drug and that drug, and they must be paying lots of money for that also.
Yep. Wait till you get the bill for COVID-19.
Yeah, and then I did get another question, and they thanked you for doing such a great presentation and want to know, what can each of us do, the individual, to advocate for Medicare for all?
So let me just offer something. I actually listened to a program this morning. Representative Pramila Jayapal, who is from Washington, a congressman. She's been very active. Folks may know that she was one of the co-chairs or involved with Bernie Sanders' campaign and was a surrogate for him. And probably her biggest input has been working with the Biden campaign on a group that's made up of Bernie folks and Biden folks. And they've been successful in kind of moving Biden to a little more progressive stance. I don't want to say left, I'll say progressive, to get them. So the fundamental idea that they have really agreed upon is health insurance tied to employment is a huge problem. And that's one fundamental thing that they absolutely agree on in trying to move that. So I would say, first of all, vote, okay, number one, because no one else is talking about any form of moving towards something that improves the healthcare system, right? And so I would say, let's get behind what you're going to hear out of the national campaign and locally as well, that at least moves the needle to get conversation about things that focuses on health insurance as part of employment, because that's a big problem. And when you go from there, I think you start looking at things more like Medicare for all, because even Medicaid for expansion is a step because it doesn't tie to your employment, but it kind of does, because if you get a job, you may or may not qualify for Medicaid, but Medicaid expansion would let you gain access to insurance as well. So that's my take. Mahree, you may have to add something to that.
Yeah, I would just say vote yes on 2 on August 4th. I mean, that's one small step we can take, and admittedly, it doesn't solve these larger problems.
And then vote at every level in the future for people that are supporting increasing or moving towards Medicare for all.
Mm-hmm. Yeah, I would definitely say, as people become more aware of the disparities in our society, whether it's race life, Black Lives Matter, or housing disparities, or whatever, when you look for the disparities that exist, then I think we should be voting for candidates who want to and understand that we need to address the disparities wherever we find them. So knowing what they stand for is really, really important.
So as I said in the beginning, this program is recorded, and people can go to the League of Women Voters Columbia Boone County Facebook page or the website, and they can share it with on Facebook. They can share it with friends and family, and it's an excellent presentation. So thank you so much, and everyone who cares and now knows more about this area should do everything they can to improve the health care in the United States and eliminate the disparities. So thank you again for presenting. Thank you, participants, for viewing. Please share. And again, thank you, Sharon Schneeberger, for making this possible. Well, hopefully you'll join us this Thursday at 7 p.m. for our follow-up sort of program, The Human Impact of Medicaid Expansion, 7 p.m. on Zoom again. Thank you.
Great. Thanks for inviting us.
Thanks.
See you, Mahree.
Bye. See you, Steve. Thank
Bye.
you very much.
Thank you.